Chairman Hatch, Ranking Member Wyden, members of the Finance Committee, thank you for this opportunity to share my perspectives on key issues in rural health and related policy considerations. While some things have changed in the 30 years I have been conducting rural health research and policy analysis, the underlying dynamics remain much the same. But we have new tools both in healthcare delivery and through public policy to help us continue our quest to establish a high-performance health system in rural America. We've had an interesting ride in policy debates and developments over that time, including weathering the aftermath of creating prospective hospital payment in the 1990s, considering health care reform in those years, major changes in Medicare payment and benefits, changes through the Patient Protection and Affordable Care Act, and now a renewed and welcome discussion of what we should be doing to best serve the needs of rural residents. I've benefited from exchanges with this committee and others throughout, starting with the conversation Senator Roberts and I had when I testified as part of the Ruprecht Health Panel, which I now chair, to the House Committee on Agriculture in 1993. We provided analysis of 5 reform proposals, including the Health Security Act, by assessing their impacts on key rural considerations. Senator Roberts may remember, and it looks like he does, sharing appreciation for the straightforward analysis that we provided, which helped give me the confidence to continue bringing forward the best we can offer from policy analysis. Of course, then Representative Roberts may not have liked the thumbs up, thumbs down table of our conclusions that my local newspaper provided, displayed during the hearing. The Ruprecht Health Panel launched in 1992 to bring rural dimensions front and center in policy discussions. We provided analysis during development and implementation of major national policies, including the Balanced Budget Act of 1997, the MMA that Senator Hatch referred to in 2003, and of course PPACA in 2010. We provided feedback to this committee and others during policy formation and followed up with analysis of rural impacts of new policies, including calling attention to unintended consequences of the BBA in 1997 before that term was as ubiquitous as it is now. I've come to appreciate the nexus of what we do in the research community with the concerns and needs of our colleagues developing healthcare services. As president of the National Rural Health Association in '96, I represented the needs of rural providers in policy discussions. One of my funded projects in the early 1990s was working with providers in Nebraska and Iowa to develop a template for a provider-sponsored Medicare Plus Choice plan. Much of my research now involves visits to rural healthcare organizations to understand the implications of Medicare and other policies on what they do. My engagement and that of the Ruprecht Center, the Ruprecht Health Panel, and the Rural Telehealth Research Center based in Iowa, and collaborations with others covers a host of specific topics of interest to this committee, including Medicare Advantage, rural ACOs, rural pharmacy, implications of changes in healthcare delivery and organization, delivery system reform initiatives, and the evolution of the marketplace in health insurance coverage, and the role of telehealth. My written testimony includes specific research findings on some of those topics, along with policy considerations. I would like to share some important questions to consider for the future of the Medicare ACO program. Are there benefits other than savings related to changes in delivery models that help achieve the triple aim of patient experience, better health, and lower cost? Should there continue to be different tracks? Should variations of advanced payment, perhaps as grants, continue to be available? Finally, what is the next iteration of payment reform that builds from the experiences of ACOs, perhaps global budgeting that we'll hear about later? I now offer the Ruprecht Health Panel's 5 rural considerations for policies designed to encourage delivery system reform. 1, organize rural health systems to create integrated care. 2, build rural system capacity to support integrated care. 3, facilitate rural participation in value-based payments. 4, align Medicare payment and performance assessment policies with Medicaid and commercial payers. And 5, develop rural appropriate payment systems. In general, policies should be sensitive to the rural practice environment, including population density, distance to providers, and the need for infrastructure investment. New models can build on the strengths of the rural system, notably primary care. Thank you for this opportunity, and I look forward to your questions.